where they are, that's where there's literally like just a flat piece of Velcro. It's like a Velcro. And as the crystals kind of get loose at times or break off from different parts in that area, then when they get back into that place, they literally just are like Velcro. It's just the most interesting thing. So, but that's where that happens, in the utricle.
Where what happens? I'm sorry.
As we go through this, we'll talk about it a little more.
Okay.
So let's look at some of the terminology. Dizziness is a whirling sensation in the head, giddy, mentally confused, off balance. When someone says they're dizzy, you need to more specifically say, what do you experience? Because dizziness can be all kinds of things, right? And also when someone falls, you need to say what was happening when you fell. Are you dizzy? What does that mean? So there's a lot of different things when you look at dizziness. So you need to kind of just say what exactly did you feel? We're going to define those a little bit more. Vertigo is when someone has a sensation of rotating, and normally these people really have to sit down. They're not just a little dizzy. They really are going, it's like their heads are going in a circle. And so that's vertigo. Oscillopia is a gaze instability, and some people have that problem. Imbalance is just unsteadiness, and this is observable. So when you say someone is imbalanced, this is you observing it, that they are losing their balance. Disequilibrium is not observable. That's when this person tells you, I feel like I'm losing my balance, but you don't see that when they're walking. A lot of people walk around dizzy in this world. There's a lot of dizziness going on. And it's just a real common thing for people to be dizzy. And I tell you that about 95% of dizziness actually is medication. And if they're on, and it's usually cardiac medication. And so if they're on some kind of cardiac medication, sometimes they have to live with it because it's more important for them to be on the medication, but it is a common side effect. But they do need to evaluate that dizziness to see if there is something they can change if it's going to make them fall, right? So if they're so dizzy they're going to fall, then we got to do something. Because as older people, if they fall, what happens to them? They break a hip. So it's very important to really evaluate this, and hopefully someone has done that for you before y'all go in and work with them. But you also need to be evaluating. Lightheadedness or pre-syncope is a feeling of faintness. And normally, what does this have to do with? Blood pressure, right? Usually, syncope, by the way, means they're fixing to pass out. You need to know that term, syncope. And so that's just a feeling of faintness. And so lightheadedness, and you need to address it, but those are just some definitions of that. Okay, so the vestibular system, sensory purposes are perception of motion and orientation. So we're looking at angular acceleration. You know, if you're going into angles, you're looking at linear acceleration, which would be straight planes. And what are the three movements that they pointed out there? Rotation, right? Lateral flexion, and then flexion and extension. So those are the linear accelerations. And then basically just where the head is relative to gravity. Where is your head at? So that vestibular, it's just like everything else. There's always information being sent to the brain even if there's not any movement. So you have that sensory information. Motor information would be control of eye movement to permit clear visual image of surroundings, and maintenance of equilibrium and desired posture. So basically, your vestibular system's helping in those areas to keep your head in the upright, or to be aware of where your head is. So that, because it's pretty important where our head is, right? Kind of an important thing in all situations. We've got the semicircular canals, and they talked about the anterior, posterior, and horizontal, and how each one of them works with the different movements. Basically, to detect angular acceleration, and this is the different ones that he just went over in that video. Endolymph moves in the canals, and so you've got the ampules, which are the dilated endings of the canals, contain hair cells embedded within a membranous material, and I think it covered that in that video. I like that video because it just kind of defines everything, and you can see the anatomy part of it. Remember that the specific gravity is pretty, you've got that endolymph is pretty thick. And have you ever turned your head real fast and it seemed like it took a little while for your inner ear to catch up with it? Well, that's what happens, because it is a slow motion. The specific gravity of that's very thick. So, specific gravity of the membranous material is equal to the surrounding endolymph. And then it senses angular acceleration through displacement of the hair cells. And so it defined that a lot. So if you need to go back and look at that video, it is in your class, in your portal. So otolith, what does otolith mean? What's otto? Ear. What's lith? Stone. And so this is basically what happens in the utricle and the saccule. You have these two little parts down there. Otolith organ senses tilts and transitions of the head, also linear acceleration, so that's where they're located. Each organ contains sensory hair cells embedded with the membranous with otoconia attached to the medial wall of the saccule and the floor of the utricle. Specific gravity of the otoconia is greater than the surrounding endolymph, not that that's important for you. Responsive to linear acceleration forces, example of gravity. And then, so you have calcium carbonate crystals, and that's what the otoconia is. And what happens is they break off a little bit as people get older. Normally it sometimes happens. Some people never have it, of course. Some people never have it. But normally it happens after the age of 50 to 60. And if it's going to happen to somebody, I have treated people who have had pretty severe concussions that have had it. I may have told you about this lady, but we treated a lady 2 years ago that just came in. She was 43, and one of her daughters was in the nursing program and had heard about what wonderful work we did. And she came in, and we ended up having to treat her twice. But she was so dizzy when she came in, she almost had to have someone, she had to hold on to somebody. And when she walked out the first time, it was so much better, she couldn't believe it. But after I questioned her, I just did the treatment one time, but she did come back 2 weeks later and we treated her again. The Epley maneuver is so simple. And what happened to her after we found out is she had fallen off of her mower and hit her head on concrete, very back of her head. And it didn't bust her head open, but she had completely forgotten about that. I mean, it hurt her head, but she didn't think about it. But probably that really is when something might have happened with her. We don't know, because she's too young to have the problem in reality. And so it's just interesting to think about those type patients. Any questions on this?
I do about the detecting the angular acceleration. So does that just mean like moving? Is that all?
Yeah, and if you're going in an angular direction, it will also tell that. Angular would be like an angle rather than a straight linear. Is that what it's talking? Is that what you're asking me?
Yeah, I get what you mean.
Yeah, because your head, it tells you where your head is all the time. So that would be a combination of two of the semicircular canals together when you're looking at angular. Okay, so some of the predisposing factors for BPPV is benign. I can't tell you. Oh, wait a minute, it's on the next one. So we'll look at it here in just a minute. Benign paroxysmal, anyway, we'll go through that. So some of the predisposing factors are head trauma, inner ear disease, so labyrinthitis, vestibular neuritis, ischemic event, Meniere's disease, bilateral incomplete ototoxicity, and if someone's had a stapesectomy. So we're going to go over all of the different terms here to make sure that you understand all the prefixes and suffixes that y'all had in medical terminology. So what is labyrinthitis? What's itis? Inflammation. And where's the labyrinth? That is the inner ear. The labyrinth is the inner ear, so that would be some kind of inflammation or some type of inflammation and maybe infection in that area. Vestibular neuritis, what's neuritis?
Nerve inflammation.
Inflammation of the nerve, so that would be your, possibly the vestibular cranial nerve. Ischemic event, what would that be? What's ischemia?
Lack of oxygen.
Yeah, so it's a lack of oxygen to an area. Meniere's disease is kind of a strange thing sometimes that happens to the vestibular area, and it's very debilitating for people. Does anyone have someone in their family with Meniere's disease? It literally will sometimes they'll just wake up and they'll be so dizzy they can't move, and so literally they have to go to bed for 2 or 3 days. I don't know, there are different causes for Meniere's disease, I believe, but sometimes it makes people where they can't work because they'll end up having to miss 4 or 5 days. And they're just very dizzy. There's some other things that happen with it, but they're the ones who feel the twirling part of it. Okay, and then bilateral incomplete ototoxicity, that would be some type of poisoning, I guess. And then the status post stapesectomy. What's ectomy? Removal. So that's when the stapes had actually been removed and I'm assuming replaced, but anyway, so when they worked with that stapes, it can also be a problem. Anytime you mess with the ear, I would assume even some dizziness comes with, have you ever had a sinus infection and been dizzy? So you know that doesn't necessarily mean that you have BPPV. It is benign I can't say that word, positional vertigo. So that's why they say BPPV. What happens is you have canalithiasis. What's iasis? Anybody remember? That's just a condition. What would lith be? Stone, and then the canal. So you have otoliths that break loose and end up in the semicircular canals. 90% of them are in the posterior canal and 8% are in the other two, the horizontal or lateral canal. And then capulolithiasis is when the otolith is free in the cupula. And so, let me go back and let's see if I need to finish this. So what we're going to look at right now is the Dix-Hallpike test. And basically that is part of the Epley maneuver where you're evaluating eyesight through the Epley maneuver. And then the Epley maneuver is just the 4 positions that we're going to do. And then we'll talk about the vestibular exercises. So what I want to do is show you the Epley maneuver. I can get to it. There's a guy that does it on his son and you can certainly go back and look at this, but it's kind of good to watch.
Hello, my name is Peter Johns, and I'm going to run through how you do the Hallpike and also the Epley maneuver. And I have here to assist me today my son Alan. Say hi. Hello. And he doesn't have BPPV, but he's agreed to help me today, so we'll just get on with it here. So first thing we do is position the patient so that they're seated with their legs up, and when they lie back, their head will be able to dangle over the bed. And then you ask them which side, when they roll over in bed, do they tend to get dizzy on? Which side is this? That one. So we think this is going to be the positive side. We'll try the other side just for fun to see first. But this is the hall pipe we're going to do. So we tell the patient, okay, what I want you to do is, on the count of 3, I'm going to lie it down quite quickly, and I'm going to want you to extend your head over the edge of the bed, and I'm going to turn your head that way. You just let me direct your head. It may make you dizzy, but that's okay. It's all part of getting you better. I want you to keep your eyes open even if you get dizzy, okay? Okay, so then I'm going to just move a little bit out of your view, but you just say, we're going to be turning this way, right? Okay, you ready? 1, 2, 3, down we go. And at this point, I look in his eyes, I might hold up his eyelid open a little bit, and because this is the negative hall pipe side, nothing happens. I wait about 10, 15 seconds just to make sure, and nothing happens. So that's the negative side. Then we sit back up. Sometimes they go like, oh, you're a little dizzy there sitting up. That's normal. But they don't get really vertiginous. Now I'm going to do the other side. This is going to be the positive side. It's not going to be positive because he's normal, but we'll pretend he is. Okay, so this time we're going to turn your head that way. Understand? On 3, 1, 2, 3. Okay, and that's 1, 2, 3. And suddenly he's going to grab the bed, clench his eyes, kind of make a ah sound because he's getting intensely vertiginous. And you're going to see nystagmus with an upward and rotational component. And now you know that the autolip is in this gear, the downward gear, which in this case is the left ear, and that's the positive hall pipe on this side, and this is the affected ear, the downward left ear. This is also position 1 of the epi maneuver. So at this point, I would just leave him right in this position for about 2 minutes. Some people I know say shorter time than that, but I think the longer you spend, the more likely you're going to get a good result with your epi maneuver. So I just sort of chat with them and for 2 minutes, and I look at my watch to make sure that's how long it took. And after 2 minutes, I'm going to turn the head 90 degrees just to the opposite side, which was the negative hall pipe side. And at this point now he will probably
He's done the first maneuver of that plane, and this is the second position.
That's good.
Okay.
The rocks are moving. So again, you chat with them. How many kids? I got 2 boys. Anyway, you chat with them for a couple of minutes, and after a couple of minutes, 2 minutes, by your watch, you ask the patient to now, I want you to turn on your side facing this way, okay? And keep supporting their head. Keep it turn right on your side if you can. It's a little tight stretcher here. And their head's going to rotate another 90 degrees now, and this is in the clockwise direction because we started here, that's 90, and then another 90. Some people say straight down, doesn't really matter. I prefer it to be like this, just remember that it's 90 degrees from the second position. This is now the third position, and we're going to go again 2 minutes in this position. And after 2 minutes, I'm going to say, okay, can you just move your feet, bend your legs so that they're over the edge of the bed there, yeah. And then you're going to sit them up. I kind of put their chin to their chest, and then sit them up, and you just leave them there for 10 minutes. I walk away for 10 minutes. And then I come back, and I do the hall pipe again on the affected side, which was this side, and if it was affected, they'll get nothing. They'll feel perfectly solid. Some people think that if you do another hall pipe, you might cause the stone to go back in the posterior semicircular canal, but that makes no sense to me because we often talk about repeating the epi maneuver, and the first part of the epi maneuver is doing a positive hall pipe side. So how could it be a bad thing to do the hall pipe again? I've been doing it for years, and I've never had a patient who was negative become positive days later. They just, once they're negative, they're negative. And I don't tell them to sleep sitting up for 2 days. I think the people who do, I bet the patients don't do it, and I think it makes no difference. And I followed my patients up, called them 2 weeks later, and they've all had, the ones who had good response to the emergency department stayed good for 2 weeks and longer. Okay, now, what if the positive hall pipe was actually on with their head turned this way? We'll go through that. Okay, so quickly.
He's going to do a positive on the other side.
We go down again, same thing, turns his head this way, he has nothing happens, 1, 2, 3, now he gets dizzy and and his eyes are all jerking around. 2 minutes in that position, 2 minutes in that position, that's 90-degree turn, and now we're going counterclockwise, right? Now the next position, even he knows now, the next position is over here, 90 degrees, 2 minutes here, and then the sit up, boom, and you're done, you're cured, you know how to do the empty maneuver now, good luck. Hi.
Okay, so, the things that are a little different that I do with him, and part of the research that shows on the Epley maneuver is, that I don't hold it for a whole 2 minutes, I hold it for about a minute. It shows that it doesn't require that much time. He probably still does it for 2 minutes. You know, you kind of get something in your mind, but I hold it about a minute. I do it exactly like he does, that's how I was trained to do it. Again, you might see some other ways, which is fine if you see something different in the clinic, because a lot of people do utilize the Epley maneuver. The other thing is you do not, when you're doing the hall pike maneuver to check their eyes, you don't have to move them quickly. You can literally just do them down slowly, and it doesn't make any difference. That's what the research shows with it now, that it doesn't require quick movements, that you can do it very slowly, and those auto lifts just get in the position that they're supposed to be. So basically what happens is you have a break off of the autoconia that is this calcium carbonate, and it becomes an otolith within those semicircular canals, and your job with the Epley maneuver is to get those back in the position where it grabs hold of that Velcro stuff and the saccule, and it stays there. And that really is what happens. Isn't that simple and weird? And I mean, it's just unbelievable. Did anybody see someone do the Epley maneuver or vestibular stuff during, and so did they do it like this? Was it similar?
Honestly, I'm not sure exactly what she did. She just had her down,
She was turning her around?
Yeah.
Sometimes you also have people that utilize a lot of head turning in their vestibular exercises. So there's many ways to do vestibular exercises. These basically that I'm going to teach you are just to work on eye movement and work so that it doesn't make them dizzy. What I normally do when I start it is I'll say, and I ask people if they're dizzy, almost always with every patient. And if the thing that's kind of a clincher, and he said it, was that if they turn their head, a lot of times people will turn their head to one side or the other and they're dizzy when they're in bed. And so if you'll ask that, is there a side, you know, when you turn your head in bed, is there a side that you're more dizzy? And they will have noticed that when they turn to the left or to the right, that they're dizzy in bed. So that's a pretty good given that it's going to be on that side. If they turn their head to the left, so I would, like he did, I would test that right side first if they told me they were dizzy to the left, and then I would test the left side, okay? Do you have any questions in here? Because we're going to go into the lab and actually go through it.
Well, what was the difference with, like, which one was that we just watched?
You just watched the Epley maneuver.
Okay.
What if, like, they tested it and they didn't see anything, but they were...
You know what? Actually, if you test it and you don't see any eye movement in the eyes, probably you don't need to do it. There have been times that I've done it anyway, because you cannot always evaluate people's eyes real. There are times where it's like this, you absolutely know that's what it is. But if I get any kind of an eye movement, or if they're made dizzy, I will do it, you know, if I see something funny. So but this is really what I'm looking for. It's so simple, why not? You know, it's a very simple maneuver for them to go through. I'm real honest with them. I tell them I really don't see what I'm looking for, but let's go ahead and go through these positions anyway. I've had more fun with this. The first time we did it, I was with Deanna Davis, and we went to see, I have no idea why I was with her. I have no idea. But we went up to a home health patient's house, And this guy was 85 years old, and he was so dizzy he could not get out of his chair, and it had just developed. He had a huge garden, and his whole goal in life was to get back into that garden. And so we just went into the house, and the other thing that you always want to do is you want to have a trash can there with you, because it's not uncommon for them to throw up on you. And so that is something, it's kind of like your cerebellar stroke patients. You need to be aware that that nausea can be a part of that. And so anyway, he was just almost sick to his stomach, and we couldn't get him out of the chair. So we literally just laid that recliner back and treated him in that recliner. And as soon as he stood up, it was gone. It was so much fun, y'all. I'm telling you, that was the most fun I think I've ever had. And it's that much fun to do the Epley with people, because you think about them. Some of them have been off work for 2 or 3 weeks because they're so dizzy, they're scared to death, really scared that they're never going to get well. And you do this little maneuver for them, and they're well. I'm just telling you, it's a fun thing to do. It's very simple, and you can certainly do your family members if you have. I mean, you're not going to hurt them.
But they only last for 2 weeks?
Oh no, it lasts forever. I mean, the girl, we ended up doing her again, but she's never been back, and that's been 2 years ago. I did have a gentleman here, and I might have seemed like I told y'all this, but anyway, I treated him a year ago. He had a total knee, and I treated him a year ago for the dizziness, because he started telling me how dizzy he was to this one side. And it was hard to do him because he had a total knee, but we treated him there at Elite, and immediately it was gone. And he came back to see us about maybe a month ago, and because he had that dizziness again, and we treated him again, and it was gone. So he knew where to come to have the treatment. Mm-hmm. So anyway, but I've many patients that we've treated over the years, and it's such a simple thing to do. You can try it. It is certainly not always the answer for them. But it is a lot of times. It really is amazing how many times it helps. It may not completely get rid of all their dizziness, but it kind of gets rid of a particular kind. So let's go into the last.